Everybody, and welcome to Chef AJ Live. I'm your host, Chef AJ, and this is where I introduce you to amazing people just like you who are doing great things in the world that I think you should know about. I am so honored to have today's guest on because he is actually my doctor. And you guys probably don't realize, but a lot of these doctors, they're working doctors. They have full patient loads and they take an hour out of their day to be here. So I just want you to know how amazing that is in itself and how much I appreciate it. If you've followed me for a while, you know that I've spent most of my 60 years living in Los Angeles. And about 2 years ago, I moved to the desert and I absolutely love it here. As a matter of fact, I'm so happy to be out of LA. The only thing that I really missed were my friends, of course, and my doctors, because having lived there my whole life, most of my doctors had been my doctors since in my 20s, almost 40 years. And when I moved here, I didn't know any doctors. Nobody had any referrals, and I was pretty scared. I had a hip injury almost as soon as I moved here. And I was so lucky that the first doctor I was referred to was Dr. Rajiv Tailor. He's not only an amazing doctor in terms of being a diagnostician and a clinician, but he's got such an amazing personality and bedside manner that I wish he was just a family practice doctor as well, because he's just really a rare find here. But he's so good at what he does. And when I tell you that he's the head of sports medicine in Eisenhower, don't say, well, then I don't need to watch. I'm not an athlete. That's a terrible name for what he does, because really what he does is make you feel better and relieve your pain without surgery. And if you know my story about being allergic to an anesthetic in my teens, there's nobody more afraid than medical procedures or surgeries than me. Well, if you don't live outside the area, you may not be able to see him. We'll find out if he does telemedicine. If you live anywhere in the Inland Empire or Coachella Valley, I really highly recommend Eisenhower in general, but Dr. Rajiv Tailor in person. And he's going to be giving us a PowerPoint presentation today. So please stay tuned, like this broadcast, share this broadcast, and please join me in welcoming Dr. Rajiv Tailor. I'm so excited to have you here.
Thank you so much for having me. That's a very sweet introduction, and you're a great patient to have, so it makes the job very easy. So I'm going to basically go over what I do and what the field of sports medicine comprises. And because, as AJ had mentioned, many people have the assumption that you must be an athlete or you must play sports to seek the care of a person like me. So I'm going to share my screen just now. So Eisenhower Sports Medicine Clinic is the name of our clinic, and this whole presentation is on musculoskeletal disorders. So there's various aspects to the musculoskeletal system, and orthopedics is basically the focus of bones and tendons and ligaments. But there are some other nuances that fall into the spectrum that may not be comprised with necessarily an orthopedic surgical perspective. So I'm going to go a little bit on to a little bit about me. I don't have a beard in this picture, but I'm an East Coaster. I was born in New Jersey, raised in Pennsylvania. I did most of my training on the East Coast, and actually last came to California to do a fellowship, and ended up deciding to start a specific non-surgical sports medicine clinic at Eisenhower. So the administration was fantastic in allowing me to do this, and I had several other business background experiences, so this really helped me in kind of slowly developing this. So this has been several years in the making, and it's been doing quite well. So to go over what is sports medicine, so specifically physicians that are specialized in training in both treatment and prevention of illness and injury. So we help ideally maximize function and minimize disability away from time in sports, work, school, just actually activities of daily living can also be encompassed in this. How do we differ from an orthopedic surgeon? So there's sports medicine specialists, and then there's orthopedic surgical sports medicine specialists. So the difference is actually the surgical side of it. So my entire training initially was on a primary care basis, and then subsequently there's a fellowship that you have to get into, and you get further training in specific orthopedic related conditions and sports medicine related syndromes. So while the orthopedic surgical side focuses on a large part of the training being actual surgical. So if you look at majority of orthopedic and musculoskeletal problems, over 90% of them are non-surgical. So many times you do go to an orthopedic surgeon, and majority of the time it doesn't result in a surgery, and a very small percent of their cases are actually surgical cases. So they again have additional training in operative treatment of these conditions. What are our goals? So all non-surgical treatment. Many people go to a doctor and the first thing they don't think is, I'm going to have surgery. Actually, people are very fearful usually that, oh my God, please tell me I don't need a knee replacement or a hip replacement, or, something else severely is wrong. So really, we need to fully understand what's going on and then really guide if a surgical treatment would be the best option. In some cases, that really truly is the case, but it is really differentiating those, and that really is a relieving factor from the patient side, because you don't feel like there's any surgical bias. So if I were to say, hey, look, I genuinely believe surgery would be your best option, people are usually more comfortable with that, because I usually try to exhaust everything non-surgically before we decide to go that route. So if you indeed were to require surgery, the other beautiful part is it's not usually a 3-month wait to get in to see an orthopedic surgeon, because the relationships that we've developed, they know that we've exhausted all the non-surgical aspects. So they're very inclined to expedite the referrals, because the next step is a surgical one, and they don't have to do any workup. They're literally, everything is ready to go, and the next step is just to discuss the surgery itself. So it's usually works very synergistically. So we don't only see athletes. Majority of the patients I see, and especially where we are actually of the Medicare population. Majority of people are weekend warriors. A lot of people that do like to play golf, do play tennis or pickleball. And then I have lots of people that literally the main function is walking around the house, going to the bathroom. I mean, it seems very minuscule in terms of the amount of activity required. However, it's all relative. So if you have severe knee pain as you're trying to go to the kitchen to feed yourself, that is a relevant scenario. I mean, that is still no different than a pickleball player sprinting to hit a ball. So it is all relative. And that's why sports medicine and what I do in the non-surgical orthopedic side is encompassing all of that. So we do with all general orthopedic issues, and even for people that are not physically active. So talking more about our community, especially locally, it's really great. It's actually a large, diverse population, many retired individuals, and most people want non-surgical options. There's new technologies. People have heard of PRP, there's stem cell. There's multiple other modalities that keep coming out in medicine. And pretty much most people would love to hear about these things. So as we progress, we're trying to incorporate those things and then also exclude those things that are not really shown to be beneficial. So there's some parts of this, which I can always take questions later on, but in stem cell and such, where there isn't a proof that it actually has done anything. There's not research done to really demonstrate how effective it is and exactly what it does. So that's a big part of the understanding, and also coming from a perspective of evidence-based medicine, and that's what I think is the most reliable to go on. So I'm not really selling magic. It's basically things that have been proven to work day in and day out. So most of our population has multiple musculoskeletal problems. So for instance, knee pain, shoulder pain, hand pain, ankle pain. So there could be multiple areas, and to evaluate that from a surgical side, you'll end up seeing 4 specialists for each specific joint. So what I do is I do everything from head to toe. So I don't have to refer unless, once again, it is specifically a surgical condition. So we can figure all of those things out. And majority of our people would like to prolong or avoid surgery if possible. So what are musculoskeletal disorders? So any injury or disorder that affects the human body's movement or the musculoskeletal system. So when I mentioned the bones, the ligaments, so yeah, the muscles, tendons, ligaments, but nerves, discs, blood vessels. So people with sciatica, it still falls in the spectrum. People with herniated discs that are causing back pain or causing sciatica. There are blood vessel issues, sometimes neuropathy related. So the blood vessel issues could result in pain that happens with walking. So there are other aspects that we look at, that sometimes knee pain is actually a nerve related thing. Sometimes calf pain is actually a blood related thing, a blood vessel narrowing. So not always does it fall into a very specific orthopedic scenario. So if you saw a knee surgeon, the goals would be, okay, well, let's look at the knee and figure out what's wrong with it. But perhaps if it was a nerve related thing that was causing the knee pain, that would be that could potentially be missed or excluded in the evaluation. So that's why it's more of a global encompassing view of the human body. And then going a little bit more on the scope of practice. So ankle sprains, joint injuries, dislocations, there are fractures that are non-surgical, rotator cuff pathology, tendinitis, osteoarthritis, traumatic brain injuries, concussions. I don't do a lot of work in that as much anymore. During the athletic season, we do a little bit of that. And there is a concussion clinic also now at Eisenhower, but many of those things are also managed by neurology. And they're usually not severe scenarios, where it usually just takes some basic management and precautions so that you don't get recurrent injuries. Certain types of nutrition. So really focusing on your general overall goals. And AJ's going to be way better at this than even I will be, but she knows quite a bit. But in terms of anti-inflammatory diets, and there's various diets out there. So many things to consider on that side as well. Injury prevention, pre-participation physicals. Again, this is mainly, I do this from the schooling side. I do cover football for Rancho Mirage High School, and we do pre-participation physicals in the local community during season. And then exercise education and promotion. What else do we do in terms of evaluation and treatment? So one thing I use on a daily basis is an ultrasound in the office. Most people have seen them in an obstetrics office, or to look at babies, or even from a cardiologist side to look at the heart. So what I use it for is musculoskeletal conditions. Why? Because we can actually look at pathology directly real time. So if I put it on the shoulder and I move your shoulder, I can actually see the fibers move. I can see the whole rotator cuff, and I can see the whole joint. Why that's really cool is because sometimes you can actually see what's wrong. So when people look and say, oh, well, an X-ray shows bones really good, an MRI shows everything else really good, and it's very detailed. However, an ultrasound is the only one that can show you all of those things in dynamic view. So you can move and watch the whole thing real time. The only negative is that it's a very small area that you can visualize. So it's even more useful when I do procedures. So when you get injections, every injection that I provide is under ultrasound. So I can watch the needle go in the exact directed place or location that it needs to go. Why that's important is because then you can guarantee that it is definitely administered correctly, and it removes the doubt of, oh, maybe it was not in the right area. And also the results from my history here speak for themselves in that people do dramatically better. So probably 70% of injections that come in that have been pre-injected before have 100% different result. And that's simply from the use of technology. And the other part is also understanding what you're doing. So there are very few people that do that, especially in the Valley, in terms of ultrasound guided procedures. So also different types of bracing options. And I mentioned cortisone injections, which there are various types, which I could always go in more detail about. Hyaluronic acid injections, those are the rooster comb injections, or they're avian derived. So now we have synthetic versions of that can lubricate areas, specifically the knees, that can help them run smoother and reduce friction and discomfort as a result. PRP, platelet-rich plasma, very interesting because I should have that hopefully in the next several months. But all it is taking your blood, spinning it down, taking out all the healing factors, which are the some of the growth factors and platelets, and removing things like the red blood cells out of it. And what you do by doing that is certain areas that are having trouble to heal, you can inject and supplement. So tendons do really well. So something like tennis elbow, this is like the gold standard for the treatment of tennis elbow. You should never have cortisone, and I'll get into more details of that. Extracorporeal shockwave therapy, again, I'm working on that. It is like lithotripsy where they break up kidney stones, but there's another device that actually works like a needle that you're able to go directly into the area and break up scar tissue. So you don't have to open or do a surgical route to do that anymore. There's technology to do that without it. Some people know about prolotherapy. It's just using sugar like dextrose and trying to inject areas that cause irritation, but then provoke a healing process. Stem cell injections, we don't do. There's still not enough evidence for it, and potentially a future. And then concussion evaluation tools. Like I said, I don't particularly do as much on this anymore. It's mainly geared towards a lot of the athletes that have had concussions and returning them back to play, but there is a concussion clinic for that as well. So the feedback, since I've started, some things that people have recurrently said, which I thought were very supportive. Most people are very happy they can get in so soon. I'm the only doctor here. So the good part is they only have to see me from head to toe, every joint issue. So that's always been a nice thing, so people don't have to feel like they have to see 4 different people and explain the whole story 4 different times. And usually if they feel comfortable, and I kind of function as the primary orthopedist, so your primary care doctor manages all of your health things and is able to direct care as needed. And I'm kind of that guy on the orthopedic world. And most people, I guess, are happy once again that they can see one person each time. So musculoskeletal disorders. So what are they? Things that are repetitive task related. So when people, are hammering or playing tennis or repetitively doing the same motion or swimming, things that are repetitive on a day in to day out situation can cause musculoskeletal disorders. Any forceful exertions can do that. So any repetitive or sustained awkward positions, some people will try to clean under a cabinet and get onto the floor, and all of a sudden that can create the rolling cycle of a musculoskeletal disorder.
Did you freeze?
Still here. Can you see me? Hello? What do I do?
Oh, hello. Oh my goodness. You still there, Dr. Taylor? I guess I'm going to have to finish the presentation.
I am here.
Oh, good. I was just kidding that of course, I'm not going to finish your presentation. Well, we lost sound, but we're back.
Okay, can you hear me now?
I can hear you now.
Okay. So, shall I resume? All right. So, musculoskeletal disorders. So there are things that predispose people, right? So force, repetition, posture, individual risk factors such as poor practices at work, the way people sit, the way people type, poor fitness, poor health habits. So all of these can be a component of contributing to musculoskeletal disorders. So this is, again, just talking about fatigue and recovery. So sometimes when you tilt to fatigue, you don't allow yourself to actually recover. And again, this is also just illustrating the same thing, where you are doing great, and then you fatigue, then you have discomfort, then you have pain, then you lose function, and that cascades into many things after that point. So let's get into common conditions. So that's where people can actually relate the most. So some of the topics that I'll touch on, which is just some of the musculoskeletal disorders that we deal with, you may actually relate to. So let's see. So tennis/golfer's elbow. So the medical terms for these are tennis elbow is lateral epicondylitis and golfer's elbow is medial epicondylitis. So this is a painful condition specifically at the elbow. And on the outside of the elbow is considered tennis elbow, and on the inside is considered golfer's elbow. Again, it doesn't mean you have to play tennis or golf to get any of these conditions. So the medical terms are, again, lateral epicondylitis and medial epicondylitis. So these are areas where the tendons from the hand all the way up the forearm attach to the elbow, and they get inflamed from a lot of repetitive motions or even injuries acutely. So you can see on the top of the hand, there are tendons that go across, and then on the bottom, to bend your fingers or make a hand grasp, they go onto the inside aspect of the elbow. So, and typically with these conditions, there's pain specifically at the bony parts of the elbow. So if you feel the very outside or very inside, there's a prominence there, and those are the epicondyles. And right next to those are where the tendons attach. And that's when you can develop tears or chronic scar tissue or inflammation that keeps, being residual and very uncomfortable. So this is an area that is extremely common, and traditionally people have had cortisone injections. Actually, in the 1980s, this was the most commonly injected area in all of orthopedics. So I'm going to tell you a little bit as to why that actually shouldn't be an area that's injected with cortisone. But again, the cause is overuse, repetitive activities. Again, not only athletes, painters, plumbers, carpenters, auto workers, cooks, butchers, anyone that does something very repetitively could predispose themselves or develop this condition. Burning and pain on the outer or inner aspects of the elbow, and weak grip strength. So some people have trouble opening jars, and that can also be the thumb, but a lot of the motions at the wrist could exacerbate the symptoms. And for testing, you really don't usually need x-rays or MRIs or anything. Just a good examination is more than enough. So we're going to cover several treatment options, and this is going to comprise most of the musculoskeletal disorders I talk about, because almost all of them are related to inflammation. And in an inflammatory cycle, it is literally analogous to a fire that you're trying to extinguish. So once you've started the inflammatory cycle, the fire is going and it continues to grow and grow potentially, and you try to put it out. So there's several ways to do that. Number one, if you remove the factors that are exacerbating it, that is helpful in allowing your body to fight the inflammation. So protecting the area, resting it, icing it, compressing it, and elevating it. That's called PRICE. These are all the basic principles for most of the musculoskeletal conditions. NSAIDs, or non-steroidal anti-inflammatory medications. This comprises medications like Aleve, ibuprofen, meloxicam, to name a few. And what they do is reduce the inflammation in the areas. It's systemically absorbed because you take it orally. There's also one that is topical, which is called Voltaren. But the goal is, once again, to reduce the inflammatory state and thereby reduce pain. So it's not considered a pain medication. The effects of the anti-inflammatory are to reduce inflammation, thereby reducing pain. So people are hesitant usually because they believe that it's a pain medication, I'm going to be addicted to it, or this is going to cause severe long-term issues. Now, things to keep in mind are, yes, if you do have stomach ulcers, yes, if you have easily irritated stomach lining, or you have bad acid reflux, or you have kidney issues, specifically kidney, not liver, these are things to consider, because then you probably wouldn't be a candidate to use this. And also if you're on blood thinners, because what this does is actually may contribute to bleeding. So if you cut yourself, you may bleed more with the use of blood thinners on the NSAIDs as well. So that's just the kind of a brief view of the anti-inflammatory options, and specifically NSAIDs. So therapy and bracing can always be helpful because, again, it helps offload the area sometimes, and stretching the area could encourage the body to appropriately heal like it's supposed to. Bracing, PRP, so that platelet-rich plasma, taking blood from you and re-injecting it into an area that is damaged, is also helpful in restarting or assisting the healing process. And then extracorporeal shockwave therapy is, again, a thing that also tries to irritate the area by breaking down scar tissue, but then provoking a healing response. And then the worst case is surgery. Rarely is that needed. People that require surgery generally have gotten multiple cortisone injections before. So touching base with cortisone, the reason it's very bad, it's not good for specifically here, because you don't want to inject tendons with cortisone, because what cortisone does actually can break down a tendon when you specifically inject into it. So anytime you get a cortisone injection, it should also be in a space, not necessarily in a muscle or in a tendon. So all the injections I do are never within structures, they're surrounding them. So that's number one. And then the reason for tennis and golfers elbow that it's really not encouraged is because traditionally when most people got them, they accidentally caused damage to deeper structures because they had to blindly go in and they just peppered the area. And by doing that, there are other supportive ligaments that they accidentally damage. So people have developed chronic pain from cortisone injections. So it's definitely discouraged. And I personally have rarely ever done that in practice, just because of the other management options that almost everyone improves with. So we're going to touch on to a very large, all-encompassing process, osteoarthritis, not to be confused with rheumatoid arthritis. This is a wear and tear arthritis. Over the years, some people use certain joints more than others, and there's also a genetic predisposition. So some people are born with tires that last 100,000 miles, and some people, they last 50,000. And also, depending on how you drive those, influences the time they will be functional. So that's just kind of a basic view on why do I have arthritis when I'm 50, or why do I have arthritis when I'm 80? So there are a lot of variables as to that. And also, if someone had trauma to an area or a fracture or break, it can predispose you to develop osteoarthritis of the area. And that also includes surgeries. So sometimes when they go in arthroscopically in knees, if you compare a knee that has never had surgery to one that did, the knee that had surgery is more likely to develop osteoarthritis. So people that have had meniscal surgeries, when they really cut away some of the meniscus. So this all happens when you lose the cartilage or cushioning that protects the ends of your bones. So if anyone has had chicken, or if anyone has ever eaten chicken before, but I know most people in this group are probably also vegan and vegetarian. So, but if you've ever seen the end of a bone, there's a really soft lining, and that's what this is. It is basically a lining that allows for the bones to articulate very smoothly, and you have them in your hands, you have them in every joint of your body. So from head to toe, from every vertebrae to every area from your hands to your toes. So there's many areas that you can develop osteoarthritis. So just to illustrate a normal joint versus an osteoarthritic joint, and very simply, if you're looking, there's a space difference. And the reason is because the cartilage is actually between the joint, and losing it loses the space. So if you lose the cartilage, now you hear the term bone on bone, which means that implies there's a complete loss of cartilage, and the bony surfaces are rubbing against each other. So the bony surfaces themselves generate a lot of pain because there's nothing protecting them. And then that starts the whole inflammation cascade. And then the inflammatory response goes up, people develop fluid, people develop pain, they have bone spurs that develop. So this is why it can become a very painful thing with time. So looking at a healthy knee joint on the left and an osteoarthritic knee joint on the right, you have areas that are devoid of cartilage or pieces that are missing. And imagine it's no longer a very smooth, silky surface. It is now a surface that's more like sandpaper. So inevitably, if you rub sandpaper together, it's just going to create friction and inflammation and pain. So on an X-ray, this is how we look at it. On the left, you have a normal joint space, and on the right, you see a loss of joint space. So the bones are essentially against the bones. So the black space in between the bones is the implied area where the cartilage is. So the fact that you can see space means that there is cartilage present. If there is no space, you know that there is no cartilage present, or there's only a minimal amount. And then you can see bone spurs that can form around the joint as well, which are all representations of osteoarthritis. So bone cannot form, or cartilage cannot regenerate, but bone can form. So it almost muffin tops, let's say. So if you were to press down, it kind of starts to wrap around the joint because it doesn't know what else to do. So that's how it basically compensates. What causes it? Wear and tear, many years, obesity, especially with weight-bearing joints, the hips, the knees, age, injury, family history. So it can affect any joint in the body, including the spine. It's an aching, painful, diminished range of motion, very common. People usually feel stiff mainly in the morning. And sometimes when they get up and start moving, they end up feeling better. And then they can feel aching again once they lay down in bed. So also very common, because as you move, it lubricates the joint. So despite not having the very smooth surfaces, there is still fluid that assists with that. And then the area could look bigger. So if you look at, someone that has very arthritic hands, and they look at their dominant hand and their non-dominant hand, the right one, well, if it's the dominant, will look wider. All the joints in the hand will look thicker. So these are all manifestations of osteoarthritis, or one knee looks wide, bigger than the other. That could be fluid, or it could be actually the bones themselves. And then how do we look at this? So very simply, an X-ray is plenty. To look at osteoarthritis, an X-ray for a majority of people is more than enough. A CAT scan is a very, very specific X-ray. It looks at the bones very clearly. It can see minute fractures very well. Rarely do you need this unless you're looking for a fracture very specifically that is not maybe visualized on an X-ray. Radiation-wise, considerably more to get a CAT scan than an X-ray. X-ray is very minimal. CAT scan is 40 to 60 X-rays potentially. An MRI has zero radiation, but an MRI also has to be used appropriately. So in the case of osteoarthritis, the only time I would ever look at an MRI is if I see arthritis, but I'm worried that there is a ton of bone swelling and there's a crack in the bone, that what it would show up like is really bad bone swelling. So you can't see that on an X-ray necessarily. And like I said, rarely do we need an MRI to look any further. But if you're specifically looking at structures like the meniscus, the ACL, the ligaments, then potentially an MRI would be useful. But if you have osteoarthritis, it kind of trumps all of that. So talking about the meniscus and such is kind of an irrelevant concept if you have significant arthritis. And then what do we do to treat it? So modifying your activities is important, especially with weight-bearing structures. So imagine your knees. So every pound of weight can be almost 4 pounds of pressure on the knees. So the more you jump and run and do high-impact activities, clearly the more pressure and further degeneration can happen, and the higher likelihood of an inflammatory process starting. So doing things like weight loss would exponentially be beneficial. NSAIDs, if you can tolerate it, the non-steroidal anti-inflammatories, as I mentioned. And typically, when I tell people to do this, I usually do a 2-week regimen. Specifically, I like Aleve because it's a twice a day. It covers 12 hours. So that means if you take it twice a day, it'll cover you 24 hours. If you take ibuprofen, it only covers you for about 6 hours. So you'd have to take that 4 times a day. So usually not convenient. And then meloxicam is another medication that apparently is supposed to last 24 hours. Doesn't never last that long, but however, it is an easier alternative sometimes to take a once-a-day pill. But very simply, over-the-counter Aleve is plenty. And doing that twice a day, and usually at the dose of 2 pills twice a day, That's 440 milligrams in the morning and 440 milligrams in the evening, is usually beneficial to try for 2 weeks. Now, again, I would not just go out and do that unless you spoke with a physician first to make sure that you would be a candidate safely to do that. So that's just something to consider. So again, therapy and stretching, you can help the supportive structures around the knee, around the hip, around the shoulder to strengthen them to be more supportive and potentially reduce re-irritation of the area. There are certain types of braces that offload areas that are painful, and that can be really helpful. And then there are cortisone injections, which again, really powerful anti-inflammatory. So my analogy of the fire, you are literally dumping a truck of water onto the fire and extinguishing it. So everyone says, well, I had a cortisone injection and it lasted me 2 years. So here's the thing, cortisone is in and out of the body in roughly about 2 weeks. So why do you still feel better? So again, if I go back to my analogy, if I put out a fire, when does it restart again? Until you restart it. There is no, there could be things that predispose you, such as arthritis or a leaky gas line. So until we find out, if we put it out, we have to see when it will restart again. So if it restarts again in a short period of time, that means we potentially have to go and investigate deeper, and it may need an excavation. So it may need a surgical option. So cortisone is very helpful in dropping the inflammation very dramatically, but it doesn't mean that this should be done over and over and over again. This is sometimes an initial starting point that potentially can reverse the cycle or stop the cycle of inflammation, and you may be good for years. And then once again, there's some cases where it's very helpful because someone may not be able to have surgery. They may have a cardiac condition. They may have something else wrong. So you're able to at least provide some degree of relief depending on the scenario. Hyaluronic acid injections, specifically, that's only approved for the knees. And as I mentioned, this is a lubricant injection. So this was derived from rooster comb. 3% of people had what we call a pseudoseptic reaction. It's an allergic reaction. We don't know who they would be. Obviously, if you're allergic to chickens, sure, you might have a more higher likelihood of it. But the versions I use are completely synthetic, so there's no risk of that. So I take no chances in that because 3% is still quite a lot. So there are options there. And remember when I mentioned when you get the joint moving, the lubrication that's natural helps it reduce the pain and it feels better. So this is like a synthetic version that we're trying to encourage that. So we're trying to add fluid that's kind of a thicker, more viscous solution that may help lubricate the joint a bit and thereby reduce the symptoms and pain and inflammation. And then PRP, there's actually some very good evidence that shows that PRP may even be more effective than hyaluronic acid, and that's using your own body's plasma and platelets to do that. So that can also be an option. And then lastly, surgery. So for osteoarthritis, a knee scope is not really of any benefit. So in some joints, they can only fuse them together and stop them from bending, such as the toe sometimes, the big toe, because it's really difficult to replace it. So there are people that do replace them, but there's mixed reviews on how effective some of the replacements are. But the traditional joints, such as the knees and the hips, very, very commonly replaced. And it can be very effective. But keep in mind, there isn't a perfect surgery. So, coming from one of the best orthopedic hospitals in the country, Hospital for Special Surgery in New York, I think they did a study showing 39.4% of people had knee pain 1 year post-op from a total knee. Now, again, it may not be a lot, but the point is that when you go in to have a replacement, you shouldn't go in with mild discomfort. And if you do that and you have a 3 out of 10 pain preoperatively and you have a surgery and you end up with a 2 out of 10, you're not very happy because you still have pain, and before it wasn't that bad to begin with. And you run the chance that it could be more. However, if it is 10 out of 10, it's severe, you've tried all these non-surgical options, and you're still miserable, and then you get a replacement and you end up at a 3 out of 10, you're very happy because a 10 is miserable. So a 7-point reduction is a win. So you got to make sure you're the right candidate and you have the right situation. So just having bad arthritis on an x-ray does not imply you need a replacement. So the combination of the two is what you need to look at. So if you have severe arthritis and zero pain, guess what? You'll never need a replacement. So these are things that we talk about in more detail. Shoulder pain. So what causes it? So tendon inflammation, people have heard of bursitis, tendinitis, or even tendon tears. So instability of the shoulder, arthritis, and then fractures, broken bones. So there's many causes for shoulder pain. I want to get into maybe a little more detail, but I'm going to talk a little bit about the anatomy. So the shoulder is a ball and socket joint. So you have the humerus, which is the ball, connected to the arm, and that articulates with the socket, which is the glenoid. And above it is the acromion and clavicle, which is the shoulder blade attachment and the collarbone. Looking at it from the golf perspective, a golf ball and a tee, really analogous. Why? Because a golf ball can rotate on the tee. It has a high area of the shoulder, has a very good dynamic motion. That's why you can raise it above your head all the way around behind your back. So it's able to rotate very effectively. And that also puts it in a situation where, because of the high amount of ability to rotate, sometimes you could injure the areas that allow it to rotate, such as the rotator cuff. What's called a rotator cuff because it helps the shoulder rotate. So you can cause irritation to that, damage to that. Sometimes people even can dislocate it. So these are all things that can happen. So we have four main areas of the rotator cuff we focus on: the supraspinatus, the infraspinatus in the back, the teres minor in the back, and then the subscapularis in the front of the shoulder. And all of them individually do different functions to help you raise the arm, rotate it internally, externally, and behind the back. So bursitis, it's kind of a really general term. There are bursa between all tendons and bones in your whole body. So there are classic areas where people talk about, like the shoulder. Oh, I have bursitis of the shoulder. It's a very non-specific term. Okay, all it means is you have inflammation. However, it doesn't tell you anything else. I have bursitis of the hip. Again, non-specific. It just means that you have inflammation in the area, and then the bursa is reacting. So you could have an underlying tendon tear, a tendinitis, or a full thickness tear of a muscle, and it could show up as bursitis, but that's just a secondary effect. So the whole goal of a bursa is the cushioning. It reduces friction. So if you excessively irritate the area, it can be inflamed and swell. So such as when you have rotator cuff tendinitis, it's not really considered bursitis, it's rotator cuff tendinitis with a secondary effect of bursal inflammation. When I talk about the shoulder, the bursa is that blue area, labeled bursa, right under the acromion, which is part of the shoulder blade, and between that and the rotator cuff. So you have the deltoid muscle, and underneath it is a bursa, and underneath that is the rotator cuff. So when I do things like injections, I guide the needle directly into the area of the bursa. And depending on how you look at it, it can be a very small area. So there are various aspects of the shoulder. And additionally, the biceps, a lot of people have biceps pain. Very, very common, and is very commonly neglected as well. So for the patients I see, over 60% of them have biceps-related symptoms. And the biceps-related symptoms are usually in the very front of the shoulder that people feel them. So people have a combination of these things that can happen. So that's why appropriate evaluation is very important to find the cause of pain. Tendinitis, again, grouping in various areas. You have tendons in your hamstring, in your rotator cuff, and parts of your hip, your ankle. So these tendons connect muscle to bone. So ligaments connect bone to bone, and tendons connect muscle to bone. So there are two types of tendinitis. You have acute, which is something that happened. You threw a ball or you reach for something, and all of a sudden you acutely cause an inflammation of the tendon. And chronic, it's been going on. Our classification of chronic is usually 3 months to consider chronic. So there are chronic diseases such as arthritis, which has been ongoing for years and years and years. So when a tendon is damaged or inflamed, it can develop scar tissue, and this pain can last for 3, 4, 5 months or for a very long time. And so we consider that chronic. So most commonly affected tendons in the shoulder involve the rotator cuffs, which is 4, and the biceps tendon. So looking at the view of the shoulder, once again, there is a capsule that surrounds the whole shoulder. So it's like its own area. So the joint itself is its own area. It's completely separated from the rotator cuff. So if only the rotator cuff is, say, injected or addressed, it has no impact in the joint itself. So this is very important for procedures because you have to differentiate whether the pain is being generated from the joint, the rotator cuff, the AC joint, which is just above there where the clavicle meets the shoulder blade, or the biceps tendon, which sits right in the front in a groove. Side view of the shoulder here, you're seeing again the anatomy. The left side is the infraspinatus teres minor on the back of your shoulder, the subscap on the other side, and then the long head of the biceps tendon rides towards the front underneath the subscapularis, way deep into the shoulder joint. And the supraspinatus sits right up top. So most people develop tears in the supraspinatus because if you see where it's located, right above it is bone. So what happens, you raise the arm up, it can pinch it down. So when people say, I have impingement of the shoulder, that's what they're talking about. They're talking about it literally pinching together, then causing inflammation, sometimes tearing of the rotator cuff. And that's usually the way it works when people develop tears. Specifically now talking about tendon tears. So you can tear a tendon. It can, split, it can full thickness tear, it could completely rip off from the bone, and then the muscle can retract. So there could be partial or complete tears. Incomplete tears, like I said, it completely pulls away from the bone. And sometimes they require actual fixing them. So there isn't a great non-surgical thing to actually take it and reattach it. And some people really do need to have surgical fixation. So that's an appropriate time where surgery is the best option. So this is very common in the rotator cuff and biceps tendon. So we take it case by case and we kind of determine whether it's appropriate or not. So going into where I said the biceps tendon, which is commonly, like I said, neglected, there are two heads of the biceps. So one of them really creates no issues functionally. So you can tear the one that attaches deep into the shoulder and you'll have no functional limitations whatsoever. However, some people have pain because the muscle tends to curl up. If you look at this illustration, you see that, well, it doesn't look like a bad biceps. It actually, some people might find it aesthetically pleasing. However, that Popeye deformity is actually from the bicep shortening because it tore away from the shoulder. Now, they will have no functional limitations. However, where it has grouped together can develop muscle spasms. And that can be pretty annoying. So some people it goes away and other people's it doesn't. So surgically, they would have to go and grab it and reattach it to an area where it would no longer tug and pull and cause pain. So one justification is for aesthetics, to reattach it to look like the other side, or the other justification is for recurrent pain. So those are things that could be discussed. But I have plenty of patients that tear it and they don't require anything. So aesthetically, they don't mind it, and pain-wise, they actually had relief of pain because it was causing pain for where it was pulling. So when it ruptured, the pain actually went away. And so if you have a situation where you all of a sudden feel a pop and you have severe bruising in the front of your arm where your biceps is, you may have torn the long head of the biceps. So it's not an emergency, but we can always discuss that, or you can speak to someone about that, and you can have some options. So impingement, where I mentioned before, where the rotator cuff gets pinched between the shoulder blade and the humerus. So especially when you raise the arm up, you'll feel that because the rotator cuff is pulling your arm up, and then it can get pinched between bones. So that's what inflames the bursa, which sits in between. So that's when people say bursitis as well. So you can say rotator cuff impingement, bursitis as a result, or tendinitis with bursitis as a result. So this is more of a mechanical view of why people develop shoulder pains. So this impingement term is that. Evaluation and treatment. History, physical, we do a thorough exam, and that's plenty. X-rays are really to assist with, some people have predisposition to develop impingement. So they could have a big bone spur that's hooking down, and hitting the rotator cuff over and over again. So that can be really uncomfortable. So an MRI can also be useful in looking specifically at the rotator cuff. A CAT scan is really useful to look at the bones, and ultrasound, which we do in the clinic, is very useful to look at most of these things. But again, a smaller view. So if there's ever a treatment needed, such as an injection, it can be guided to the area where it needs to be. So what treatments? Activity modification. So if you have impingement, doing overhead serves, playing tennis is not your best thing, or swimming, or doing just any activities above your head repetitively would further exacerbate the symptoms. So modifying what you're doing could be helpful. And if you can avoid doing those things, that would be beneficial. Protection, rest, ice, NSAIDs, similar to what we discussed, therapy, stretching, cortisone injections, hyaluronic acid. Now, again, I put it there because some people have gotten hyaluronic acid injections to the shoulder joint, similar to the knee joint, but it is not approved and it is not covered by insurance. So I wouldn't encourage that. I would never recommend that to be an out-of-pocket expense. PRP, however, once again, is a really good way to help heal an area. So if it's a partial thickness tear or an inflammatory thing, it could be helpful in healing. And then surgery is, again, last resort. Arthroscopy, where they do laparoscopically, and they go in arthroscopically, and they are able to look at the areas and fix them and suture them back together. And in the worst case, replacing the whole joint. And that's usually when you have bad arthritis, or when you have no rotator cuff to repair. They do something called a reverse shoulder. So it reverses the ball in the socket. It's quite intriguing. It's extremely effective. So there are people that are very good candidates, and they do a lot of them out here. We're going to jump to the next topic, carpal tunnel syndrome. Very common, pain, numbness, tingling in the hand. It involves a specific nerve called the median nerve, which runs on the very inner aspect of the hand, the volar aspect of the wrist. So anytime you increase pressure over the area and do anything repetitively, it creates inflammation because all of those tendons slide under the wrist, and the nerve happens to be there. So if things get inflamed, it presses on the nerve, and then it sends a signal that's a numbness and tingling and discomfort into the fingertips. So it's very common for people that do repetitive tasks, such as typing or poor wrist posture when they're typing, or if they're lying their hand on something repetitively, that can do that. So another visual of what I'm talking about. So what holds everything kind of together, well, this is just what we were born with, is the transverse carpal ligament that goes right across the wrist. So that holds all these structures down and in place. And it's just another extra supportive structure. Now, the nerve is the yellow object that goes directly underneath it. So if it's inflamed, there's a confined space, and that inflammation develops fluid and swelling, and that compresses the nerve. So when people get injections to this area, it reduces the inflammation and reduces the pressure on the nerve. Alternatively, you can look at, this is just another illustration showing where it gets compressed. Alternatively, they do a surgery to actually cut that ligament and then open it up so that it relieves the pressure on the nerve. And that's, again, the worst case scenario, and that's also very effective. So what causes it? Hereditary, repetitive hand motion, the wrist position, pregnancy. Actually, you increase your fluid volumes, and actually some things are more likely to happen in pregnancy than in a non-pregnant state. And this happens to be one of them. Health conditions, diabetes, rheumatoid arthritis, thyroid imbalances, and then symptoms: numbness, tingling, burning, pain involving specifically the thumb, the index finger, the middle finger, and half of the fourth digit as well, the ring finger. The other pinky and part of the ring finger are actually a different nerve. So very specifically, keep in mind, when you look at your hand and it's on the inside and at the fingertips, which fingers does it encompass? And that's the most important thing in differentiating carpal tunnel versus potentially a neck issue versus potentially an elbow issue. So an EMG is a nerve conduction, it's basically nerve conduction studies. So there are different types of them. And what they do is they test the signals that go down the arm, and they test conduction delays. So let me give you an analogy. If you're looking at a pipe and you're looking at water that has to go from one end to the other, and all it does is basically tell you the flow of water. So if you have a kink in the pipe, there's less water coming out the other side. And that's all an EMG does. It sends a signal from one side to the other. And if there's a kink, there is basically a signal delay. And in that signal delay, you can detect if there's something wrong with the nerve. So that's why it's really helpful in determining nerve damage. So if this has been happening for a very prolonged period of time, you can actually see it. However, if it just happened, you may not find it. So these are all things to keep in mind. X-rays, ultrasound, MRIs, all things that could be useful, usually not needed. And again, the ultrasound from my perspective is to help injections to this area. Bracing and splinting, night splints, are very effective. People wake up with numbness. Why? Because they sleep kind of odd. We never know what we do. We do all kinds of contortionists at night. So we can be in a position where it can be really uncomfortable. We wake up kind of, flicking our wrist and our hand because it just feels numb. Like if you sat the wrong way and your leg fell asleep, imagine doing that all night. And so in an area that's already hypersensitive. So bracing it in a neutral position is helpful so that you won't continually irritate the nerve all night. And that can be in itself very helpful if you do that on a regular basis. NSAIDs, again, reducing inflammation, helping the area. Activity modification. If you're a person that types a lot, changing that or modifying the posture can be helpful. Therapy, cortisone injections, and then lastly, surgical release of the ligament, which is illustrated right here, which you have a divided transverse ligament. So if they just make an incision, cut it, it's a very simple procedure and very effective for people that don't respond to all the previous mentioned conditions. So other conditions that we treat, again, Achilles tendon injuries, tears, ankle sprains, ligament injuries, knee meniscal tears, hip labral tears, hip impingement, minor fractures. We talked about rotator cuff injuries, foot pain, problems, shoulder dislocations, tendinitis, frozen shoulder, trochanteric bursitis, and plantar fasciitis. These are just throwing out a bunch of terms, but many of them are just keywords that people remember or they may have heard in the past for themselves or friends or family. So these are all things that we really treat in this clinic. So ultimately, what do these solutions mean to you? One musculoskeletal provider for all your non-operative complaints. Being sports medicine, I would call myself your quarterback, but we basically function to make all recommendations and manage all of these conditions under one roof, and then guide surgical referrals if indicated. So all of those things are very much expedited once we figure out exactly what has to happen. And in over 90% of the cases, they will be non-surgical. So we improve evaluations and we waste less time or resources. So we don't have to order things that are not helpful. So if you have severe arthritis in the knee, guess what? An MRI is completely worthless. So there's no point in doing all these extra things if they're not going to yield any benefit. So this is where we really focus on. So this concludes my presentation, and I'm willing to take any questions anyone has. So AJ, if you have any.
Oh my God, thank you. That was amazing. This is the kind of thing that I'm going to have to watch again. I feel like you were talking to me and about all my injuries. It was almost like you made this presentation just for me.
So great.
Yeah.
I'm happy that definitely to touch on very common topics that most people have. So
if you'd like, you could stop sharing the slides so then we could see all of you. And yes,
okay.
Some questions have come in and I'm not going to be able to pronounce all the words, but one of the things I want to ask you is why does it seems like so many doctors are, you use the steroid injections very judiciously. You don't just come in and you don't give everybody a shot. You're yes. very thoughtful about its use, but so many doctors seem to frown upon the use of steroids in general and warn patients like me. That's why it took me so long to get help, because they're like, no, don't get a shot. Like, why are so many people like that when it comes to that? Like, don't get a shot, don't get a shot.
Yeah, so there is truth to it. Okay, so if you were to get an injection every 2 weeks, it's not good for you, mainly systemically. So some people are on oral steroids every day because they have some rheumatoid arthritis or something else that requires a reduction in inflammation on a daily basis. So there are conditions that require steroids every day, and that's where it really gets kind of a bad rep. because that causes other issues. There are other syndromes that can be caused. It elevates blood sugars. It reduces your immune system. So yes, there are definitely negative effects of steroids utilized on a long-term basis. From my perspective on injections, the negative happens with one thing is inappropriate placement. So if you inject a structure, you can damage the structure. So if you inject the knee joint, it's a big space. But if you inject the quadricep muscle, it can cause degradation of the muscle. Or the tendon of the rotator cuff, you don't want to inject the tendon itself. Or the tennis elbow, injecting the tendon causes damage locally. So if you inject around it, it calms down the area. And generally the bursal areas are where we go. And if we do that, then it distributes it all around and calms the whole area down. So there's less detriment to injecting an injection if you can guarantee its placement. But secondly, there is a detriment despite that. Now, that's with repetitive use. So if I were to inject your knee every 2 weeks, I will further predispose you to develop arthritis because it is weakening the area. Now, again, it's all about frequency. So we have these guidelines or recommendations that say no sooner than 3 months, and that applies to a specific joint. So I would not inject the knee joint within 3 months. However, if the shoulder was a separate area altogether, that's totally fine. So the systemic effects, like I said, are an issue if you're injecting on a really frequent basis, but most of these medications are out of your body in 2 weeks. So if you're 3 months out, that steroid has been in and out, it has zero effect on your next one. So that's something to keep in mind. It's the frequency and it's the location and placement. That's very important. So I've had many discussions where people are like, they're opposed to a steroid injection, which I completely understand. However, they're afraid of the systemic effects and the general fears of it affects on your body. So let me ask you this. So most people that have pain and they live with this pain and you try a lot of conservative things and they don't work and you develop secondary issues, you change your function, you change your habits. So if you have severe knee pain and you used to walk every day and now you no longer walk, you're reducing your cardiovascular activity, you're reducing your lung activity, and that causes you to become depressed and increases your stress levels. So from my perspective, you're basically harming things that are way more important than your knee joint. So a knee joint, there are options. It's not easy to replace the heart. Your brain health is way more important. So don't live in stress and pain because your cortisol levels will go up. So if you talk from that perspective, living in chronic pain is much worse than one cortisone injection. So I weigh that in all the decisions I make.
And I love that you mentioned that every pound somebody is overweight is like 4 pounds to the joints, because I think that in some cases, some people would be helped so much just by some dietary and lifestyle changes before they even come see a doctor.
Absolutely. Absolutely. Yeah. And here's the other thing. It's also tough, right? So let's say you are very overweight and let's say that you want to do activities. So it's really difficult. So even if you want to do physical therapy, but you're in so much pain, you cannot. So hence why when I say steroid injections, my goal is to help assist with the rehabilitation or the weight. So if you can't use a treadmill or you can't swim in the pool or you can't use a cycle to help you, right? And diet is a huge component, as you're aware, but also cardiovascular activity would be great. So if I can assist with that, then we can accomplish both goals together. And then for the future, you may never need these injections. You may never need these medications because now you've reduced the weight.
Does your mother know what a good doctor you are?
They always brag about me being a doctor, but well before I even say anything, they're like, "Oh, do you know he's a doctor?" I said, "Oh, yeah. Well, thanks." That's.
I mean,
I
you
always
really
have to tell them to be quiet.
Can people? I know with COVID, telemedicine has become very popular, but can somebody? There are people watching that would love to see you, but they don't live in the Coachella Valley. Does Eisenhower allow that, or are they very strict?
Honestly, I haven't been doing a lot of new patient visits via telemedicine. We definitely do follow-up visits and such via telemedicine. Or established patient visits via telemedicine. It's just tough because I am very hands-on and I like to examine and some things just history is very important, but I have limitations as to what recommendations I can truly give you unless I have an accurate diagnosis. So I don't really prefer doing that simply because I can't give you an honest opinion of what's wrong.
You're sort of like an MRI machine in a way, because like everything that you've ever done with me, it's like the report, you already had it before the machine confirmed, you know what I mean? You just, I don't know how you do what you do. You just like, go like this, and then you say what it is, and then it's confirmed on either X-ray or MRI. It's almost like you're better than the machines.
The focus really should be on, in my opinion, your history and your exam. And people neglect that. That is very important. That is you tell me your diagnosis better than any machine does, because even the machine can't tell you what's wrong. And it's all, again, subjective. The radiologist is reading it. The image itself, maybe it's not clear, or maybe it's blurry, or perhaps it's an area that's commonly neglected. So these are all things that you're more reliable, and the person touching you to examine you is also likely a higher reliable resource if they use that as part of their diagnosis.
Great. So there's a question from Jay, if carrying a heavy purse can cause bursitis in the shoulder or other issues.
So yeah, a repetitive use of, say, a heavy purse on one side. So just the way you move all day, just the weight on it itself onto the shoulder, it can cause it to droop a little bit. When you pull your purse out off your shoulder, does it slide off? Do you pull it off? And when you pull it off, you're in a position where you can also injure it. In some cases, that's what's really heavy. So it's, again, a more repetitive task done on one side versus the other on a daily basis. So yes, there are things that can predispose you to developing shoulder issues. And the weight itself, not necessarily directly the weight itself, but it's the side effects of the weight that can do that. Unless you have AC joint pain, which is right at the top, which is uncomfortable when you press on it directly. So,
nice. So Deborah says she had rotator cuff surgery, and now every time she reaches, she hears a clicking noise. Is that normal?
So many people have sounds. So people always remember sounds. So their knee clicks a lot or the shoulder clicks. So I wouldn't worry about that. It's usually when it relates to pain and clicking, then it starts to become something we may need to look at. So the shoulder is so dynamic, as I showed you. You can rotate it, you can move it. So things inevitably do sometimes click. The bones may get in proximity of each other, or the tendons themselves may move slightly. So the clicking things, and you'll see this from a 20-year-old to a 90-year-old. I mean, the sounds can be present all through life, but we do focus on them when there's a problem. So all of a sudden, and I'll give you something that's not even related to musculoskeletal. So somebody I knew felt like they could hear their heartbeat when they lay down on their pillow. Well, if most people were to lay down on their pillow and put their ear to the pillow, they may hear their heartbeat. So it's not an abnormal finding, but it is something that causes anxiety when you paid attention to it. So many things have potentially been there for a long time, but you're not aware of it because you never really paid attention to it. And they're actually normal things that can happen. So clicking, for the most part, my knee clicks on a daily basis, but I don't pay attention to it. But if I do focus on it, I say, oh, wow, it does click. So these are things that can happen very commonly.
Nice. Now, two people are asking about if there's non-surgical remedies for something I'm not going to be able to pronounce. Dupuytren's, Dupuytren's.
Dupuytren's contracture. So yes, there is. So Dupuytren's contracture is when there are tendons in the front. So what happens is the tendon fibroses and thickens, and then it looks like the finger starts to bend. Okay, and then the tendon protrudes off the hand. So what happens is and that's really a immune-mediated kind of response. Some people develop it. Some people just develop it. I mean, their father or their mother or somebody had it. So potentially genetically. But so anyway, what happens is it develops all this fibrosis in tissue, and progressively it can bend the fingers more and more. And there's a certain point where we do a table test basically to see how much it's bent. And at a certain point, we recommend a treatment. Now, there are treatments to go in and break the bands of tissue, even with a needle. And there's another thing where they use an enzyme to break down and loosen the tissue, and then manually, forcefully extend the finger, and then it cracks all of that open. Now, okay, it sounds really barbaric, but it's very effective. I don't do that mainly because sometimes you risk a rupture of a tendon, and obviously a hand surgeon will be the guy to repair it if that happens. So that is the only reason, really. But That we can definitely talk about as an option, but that is a non-surgical option in the sense that you can do that. So it doesn't always require surgery. And there is evidence that surgery in that case, you may have all of that just happen all of a sudden again, because it is an inflammatory response. It is an immune response. It does fibrose. So if you go in and cut it, it will just refibrose again. So it's not a perfect thing.
Great. Kathy said she had a PRP injection in her knee and it really helped. How long should she wait to have another one?
There is no duration of time. There is no frequency that's recommended. It is really symptomatic. So if you have no symptoms, there's really no indication for another one.
Yeah. So here's a thing I get all the time: ice or heat? How do you know which to use? And because I hate ice, I hate it. I'm so cold all the time, so I don't like it. And I know that sometimes it's warranted over heat, but heat feels a lot better.
So in cases where, all of these are mitigating blood flow in some way or shape or form. So let's say you want to loosen an area that's really tight, okay? It's not acutely irritated like you woke up with it, okay? And you want to loosen things up. A shower, a hot tub, a warm towel, it'll help loosen muscles that are more contracted. It'll increase blood flow to the area. So, but an area that's acutely injured, or an area that throughout the entire day is super angry and there's a fire, right? I would look at it that way. If you started a fire and you want to put it out, you're never really going to put ice on it, or you're going to put water on it. So you want to cool it down. So that's just a very basic way to look at it. If I'm really inflamed right now and I did something, I should want to ice it and cool it down, not put heat on it necessarily. So there are variations to that, but for the most part, if you acutely injure an area or it gets really inflamed and severely painful, go with ice. If you want to loosen yourself up, go with heat. So, and it's a soothing heat that can be helpful. So even at the end of a day, sometimes you may even feel like heat feels better because the muscle now is resultant spasmed. So it's really good for the musculature, but the actual joints themselves, it doesn't do a whole lot for necessarily the joint itself when it's already in an inflamed state. So sometimes ice is more helpful. So it is kind of variable. It's tough to predict every scenario, but just a rough way of looking at it. That's how I'd look at it.
Mary wants to know, what about trigger finger?
Oh yeah. So trigger finger, it is there is a pulley, and there are pulleys across the entire hand under each finger, and it tethers down the tendon. So every time you bend, it slides underneath this. And some people develop a nodule. And when you develop a nodule, which is thickening from repetitive things, such as grabbing things or just repetitive motions, it develops thickening. And when it thickens and you bend your finger, it pops underneath this pulley. And then when you go to extend, it gets locked, so it can't. And then it all of a sudden pops back through. So the reason is inflammation here. So very commonly, we do injections to basically right to that area to calm down the inflammation, reduce the swelling, and then it should go back to normal. However, if you're a diabetic, you are much more likely to develop it and fail injections requiring surgery. And the surgery is tiny. I wouldn't even consider, they used to do it in the office. I mean, it literally is a tiny incision here, and they snip the pulley, and that's it, and they close it. It's a really, really minimal surgery, so it's also very effective.
Wow.
But a lot of people do well with just an injection.
Yeah. This is a really interesting question from Jennifer. She says, what does he think of PRP in fingers for hypermobility, like in PIP volar plates? I'm a professional symphony string player, and it's been a problem. Where do you play? That's so interesting.
So I cannot say because there isn't any evidence for it. It's just would be experimental. So PRP is so benign that I say for the most part, if it's not a financial burden and you want to try it, there is no harm to it. So I'm not opposed to it, but I also can't say that it would do anything because genuinely there's no evidence for it. So, but I'm a proponent of anything alternative, vitamins, and there are very many other solutions in terms of just anti-inflammatories from turmeric to omega-3 fatty acids. So people like to go those, and there's nothing wrong with that. And there is some evidence that there's some benefit to it. So, but particularly in the hand, PRP, it's still, I cannot state that there's much evidence for it. But given the high demand you have, and given the diminished side effects. So cortisone is going to be more detrimental for you than PRP. So if you're going to do something and you wanted to try it, PRP could be an absolute option.
That sounds great. Do a lot of people, what's the most common thing people see you for, Dr. Tailor? Is it back pain? Because a lot of people here are saying, what do you do for back pain? Get an MRI, but they should see, if they can't see you, they should see somebody, not diagnose it themselves.
So most back pain, it's one of the most common things in the primary care world. And most primary cares manage it just fine, because really exercises, PT, dynamic changes, losing weight, all of these factors will help back pain. So working on your abdomen, your core, and your low back, that is the fundamental basis of this. Anti-inflammatories can help you do that, reduce pain and inflammation, and help you strengthen. But in some cases, is just too much arthritis, or there's too much disc loss that can cause pain. And in those cases, and I do see a lot of that, but we do see shoulders, knees, most commonly, hips, but back is very commonly seen. And the only limitations I have are procedurally for the back. They require fluoroscopy. So there's certain procedures that can be done to the back via injections that people see pain management specialists. So look at what I do as interventional orthopedics, right? There's one segment that is all the peripheral joints, from the hands to the toes to the hips to everything. And then there's a component that's called interventional spine, which is not spine surgery. However, their focus is the spine, and they're basically pain management specialists. So they don't only dish out meds, they actually do intervention specifically to the spine.
I love that, interventional orthopedics. I've heard it for cardiology. That's very cool. Well, there's over 200 bones in the body, so you probably are very busy.
There's a lot of places. So yeah, I see a lot of the same patients for multiple other things.
Yeah. Well, I want to respect your time. Maybe we'll get to have you back someday. There's so many questions, but I do want to ask you one thing about osteoporosis, because as you mentioned, I'm vegan. My audience is largely vegan. And a lot of us vegans get diagnosed with osteoporosis, but the plant-based doctors don't seem to worry about it so much, because say there's no evidence. It's because a lot of times we have lower BMI, we're thinner, but at least the plant-based doctors that I go to say there's really no evidence that vegans have weaker bones.
Yeah. So there are a lot of things in terms of vegans, in terms of their body mass index. So their bone density, sometimes you're right. If some people are not eating enough or not eating the right nutrition, yes, clearly you may have a higher likelihood of developing osteoporosis. There's also genetic factors to that as well. So you can't just generalize it. So the calcium intake is also really important. Vitamin D intake is also really important. So, it really depends. There are studies that show calcium intake and the incidence of fractures. So they've studied these things, and they've shown the ratios. And I think for fish eaters, it was like 1.05. Vegetarians, it was like 1.02, and vegans, it was 1. So, I'm not really sure about the specific relationship, if it's definitive, but if you're eating enough calcium and vitamin D, I don't see how that would be just because you're vegan. Does that, imply you're going to have osteoporosis? So no, I wouldn't agree with that.
Right. Because I had this one doctor in LA, my diagnosis was, it was because I was vegan. So, but thank you.
No.
So you're amazing. Thank you so much. I have such enjoyed your presentation. I'm going to have to watch it again for the particulars, but you're just such a wonderful doctor and just such a kind person. And I thank you so much for just being here, because I would hate to have to drive to LA.
No, I appreciate your praises, and that it does encourage me to do what I do, and I enjoy what I do. So, well, thank you very much for having me.
My pleasure. I don't know if you noticed, but I gave you a 5-star review on Health Grades, and I hope everyone else will as well.
I did, and you can see yourself right there.
It's funny. Some people notice the book in the background. I call that subliminal marketing. Thank you so much.
My nurses did all this other stuff here, because when they published the article, which I think you might have or send later on, they did one in Eisenhower's Health magazine. So they thought it was funny to make fun of me being in the article.
Well, that was a great article. And if anybody wants it, I'll link to it in the show notes. We sent it out to our mailing list, and your staff is so kind, from the front desk person. It's like when you have a good doctor, it's like everything is great. I hope you don't leave. Please don't leave.
No,
you can leave.
no, I don't plan on leaving.
Yeah. When I'm dead, you can move.
Well, then it's going to be a long time. Maybe.
Oh, probably. Thank you so much, Dr. Tailor. Thank you, everyone, for watching another episode of Chef AJ Live. Please come back at 1 p.m. today when we have someone else that's very interested in the musculoskeletal system. He is a staff doctor at the True North Health Center, and his name is Sadiq Shiraz, and he's going to be talking about the physiology of movement. Take care, Dr. Tailor. Thank you so much.
Take care.